wound durations, healing times. So it is very widely used, and tremendous progress has been made in its wide application and research in the they are not so high, and a lot of randomized clinical trials are needed. So the treatment of diabetic foot wounds is a cross-disciplinary and needs a very systematic or organized approach to heal it. And NPWT is one of the very important adjuvant or the adjunctive therapy, which will, but it has certain prerequisite conditions like wound infection should be well controlled, the risk of bleeding is well controlled, and potential bleeding and the wound infection should be controlled. And then during debridement, prior to its application, we should take care that the infection and the hidden foci of infection, the fascias, they should be taken, they should be checked for the presence of infection and should be eradicated during debridement. A good culture, deep tissue specimen must be sent for the culture, and biopsy of the wounds must be done so as to see the evidence of healing. The risk of bleeding should be well controlled. Potential bleeding and the INR potential and coagulation profile should be taken care of. The INR should be in the range of 1 to 2 should be done prior to application of the VAC. And because with the application of negative pressure and higher negative pressure, sometimes there may be the risk of ischemia should also be well controlled. There's adequate wound and distal limb perfusion should be checked before. TCPO2 should be more than 40 range. ABI should be 0.9 to 0.3 or TBI more than 0.6. So other parameter settings, which include the negative pressure, should be ranging from between -125 and -80. And for vascular and stenotic lesions, we'll have lower pressure range between -80 and -60. And these are recommended so as to prevent the bleeding. The mode of NPWT should be it may be either continuous, intermittent, or variable mode, but better results have been obtained with the variable mode. So the continuous mode, to understand, is a continuous mode where the continuous pressure range is stable, that is either somewhere between -125 or 80, and the pressure, negative pressure, remains consistent and stable. This is less commonly used now because of the pain it causes, and maybe not be acceptable by the patient. But the intermittent mode, where there is the 5 minutes on and 2 minutes switch off, so there is sudden increase and lower of the patient, which again is very uncomfortable for the patient. And the new one which has come up is the variable pressure therapy, where there you have certain negative values, so it may be between -80 and -10 or -20. So it is more comfortable for the patient. The pain is less, and it maintains a uniform negative environment. So apart from the specific the specific applications of NPWT according to these guidelines may be infected wounds, where I've already told, and wound osteomyelitis, where it should be used with caution, and continuous close monitoring of the wound is necessary, looking at the wound edges, wound margins, the color of the wound, if there is any bleeding or pus or exudate or foul odor should be looked into. So a lot of caution is needed after skin graft or flap transfer. Continuous negative pressure should be maintained for 5 to 10 days, 7 days. Similarly, for the grafted wounds, also with dermal equivalent, similar consistent pressure may be maintained for 3 to 5 days, negative pressure. And after extremity or toe amputations with conditions of primary suture, we have to maintain continuous mode of thing for the -80 to -60. And in ischemic wound, it has to be again done with caution, and lower pressures have to be started, and the wound monitoring is essential. So wounds after extremity or toe amputation without the condition of primary suture, we use lower pressures, and it is recommended in Wagner's grade 2, 3, and 4, but not recommended in grade 5, 1 and 5 diabetic foot ulcers. So the primary to understand the mechanism of the NPWT working, it was Moriqua's animal model was used as a facilitator, and for the ideal wound healing, to provide the ideal wound healing environment. And with NPWT, there is actual indrawing of the wound edges to bring it together to ensure that there is wound contraction, and there is the wound is cut off from the surroundings with the help of the plastic cover or cellophane, so it maintains the reduced microorganism or no microorganism level and amicable environment for the wound healing, reduces the wound edema by washing away the exudates, and there is micro deformation to stimulate the bed of the wound for cellular proliferation and angiogenesis. So the secondary effects may be stimulation of the cell proliferation, release of growth factors, and reduction of the inflammatory cytokines, increased angiogenesis, indrawing of the blood from the periphery of the wound, reduction of inflammation, and enhanced granulation tissue formation so as to decrease the bioburden. So NPWT is a great modality and has expanding dimensions almost in the wound healing area. And again, as we have already seen, we have to carefully select the wounds, and debridement prior to the application of VAC is essential, and wound biopsy and wound deep tissue should be taken for the culture. You have to rule out, you have to see whether there is wound ischemia or there is an infection, osteomyelitis, or sensory neuropathy. And so debridement should be radical, and it should be free bleeding edges should be there. So the common goals of NPWT is to promote rapid reduction in the wound volume, promoting wound contraction, growth, enhancing the granulation tissue, prepare the wound bed for another procedures like skin grafting for wound cover, and reduces the bacterial count and decreases the overall hospital stay length. And it may be even economic in this way, that it reduces the hospital stay length, even though the initial cost may be higher. So it decreases the frequency of dressing change also, and very comfortable for the patient, prevents the wound deterioration and contamination, wound odor, improves the quality of life. So, but we are at the application, as I've already told, we should also not only inspect the wound and monitor the wound throughout the process, but also do the preliminary healing markers like hemoglobin, albumin, pre-albumin, WBC count, creatinine, and appropriate antibiotics, initially broad spectrum, followed by the culture-specific antibiotics must be given to the patient. So, what are the indication or when we should do the NPWT? The recommended for mains powered negative pressure wound therapy are usually the acute and the subacute or the traumatic wounds in general, and the pressure ulcers, large pressure ulcers, venous stasis, large venous stasis and painful ulcers, meshed grafts, and adjunct to skin graft and flap procedures. Almost same for the battery powered ambulant negative pressure units for home care, etc., where it's mainly not the acute wounds we are not dealing, but almost the same things we are doing. So it can reach the home comforts also with the use of portable NPWT devices. And this is the our NPWT device which I am using at my center, and it is made not a very big company, but it is giving this is a battery, and you can see the entire appliances which are needed, and you can have a battery, a canister, the tubing, and then you have a connecting tube, you have a foam, the sealant, and small tubing connector to be there. So the Y connecting tube to connect two places if the vac is at two places, and the suction pump. So you can see it, and you can, with the help of the this thing, you can change the settings with the help of the buttons. And also it is battery powered. So with the foams which are used are very important, which help in the growth of the granulation tissue, and they're in direct contact with the wound bed. Polyurethane foam it gives the fastest granulation, but it has larger pore size, and hence the granulation may grow into it, making it very painful. Also, it may even cause ischemic necrosis by blocking the smaller vessels and hardening them. So this is usually less recommended, but it causes thick and faster granulations, but there are more chances of fibrosis after using with thick granulations. So you get a thick granulation with PU foam. Polyurethane ester, where it is more used in the instillation vac and removal of thick exudate material like fibrin, slough, and thick vac exudate and other infectious material. Is used, and it also has a honeycomb structure, which allows the ingrowth of the granulation tissue, but to a lesser extent than PU foam. Another is polyvinyl foam. It's also hydrophilic, more elastic, and it's also used for the same purpose. But we prefer, nowadays we have gone over to the gauzes, which are impregnated in PHMB solution. The ingrowth of the granulation tissue and removal is easier, and it's more comfortable for the patient, more cost effective also. So this is the application seen at more than one points at for the extensive debrided area. You can see how it is applied, and the you can see that. So now the application, we can see that initially the wound is inspected carefully apart from at the bedside, then it is cleaned thoroughly, and after a thorough cleaning, watching the web space for infection, we then cut the foam to the size of the wound. It should not go outside the wound confines, and then apply it on the wound area, and then we apply tincture benzoin around it so as to allow the sticking of the cellophane or the that sheet that seals the wound. And then we can see that how it is used. Cellophane sheet is applied over the tincture benzoin, which is applied to the surrounding edges of the outside the wound edges, and then a small hole is made over which we can keep this eyelet, and then it is attached to a tubing. So you can see that, and then once attached to a tubing, it's attached to the suction pump, which I had already shown you, and the settings are adjusted. So the pressure, cycle, and duration I have already spoken to you, and it is important that in the wounds which are ischemic or having the skin grafts, in the skin, those with ischemia and infection, mild infection, we have to give a relatively less suction to them. And also those which are the wounds which are larger need more negative suction. And then the wounds which have the which are grafted or even the skin tissue equivalents are applied, dermal substitutes are applied on those wounds. We apply a low level of intermittent suction to them, that is 5 minutes on and 2 minutes off intermittent suction, or a variable mode of suction, that is preferred. Initial consistent negative suction is applied for 5 to 7 days up to a week's time in the patients in whom dermal substitutes are used, or the grafts are applied. For dermal substitutes, even 3 to 5 days continuous suction is enough. And those wounds with vascular occlusion or stenotic lesions, we use a lower pressure range like 80 to 60, depending on the size of the wound and the need of the need as per the need of the patient. So we can see also take into account that which apart from which wound filler and what pressure to be seen. We see that that antibiotic has to be taken. Which antibiotic we are giving, whether the patient needs home care or portable devices can be used. So again, as I have told that in the wound periphery, the blood flow actually increases after 2.5 centimeter from the wound edge, so as to draw more blood to the wound area. Then immediately in contact with the wound edge, the blood flow actually decreases so as to enhance the angiogenesis and the granulation tissue formation. So this is how the NPWT works and increases the inflow towards the wound area by exerting negative section. So complications can be, the most feared complication is the bleeding, spread of infection, maceration of the surrounding edges. And these may be, the maceration of skin may be due to technical issues of leakage, etc., or more pus forming suddenly, spread of infection, and bleeding may be there. So the long-term, short-term complications may even include severe bleeding and pain and rupture of the heart, and in long-term may decrease the quality of life or even malnutrition. So the when to discontinue NPWT is that when you have achieved the desired goals for the wound, and you have to you have the effective or the very excellent granulation, very effective granulations, less effective, and no non-effective wound bed. So depending upon the amount of granulation and angiogenesis, we decide that, and exudate volumes have reduced, and the wound is prepared for the graft. So failure to improve in the wound, we have to stop it. And again, the complications are developing like bleeding, etc. We have to stop it. Poor patient command, patient is not tolerant, reducing with pain, blister formation, allergy under the cellophane sheet, they will not tolerate it. So we have to avoid in this in these patients. So if they are exposed blood vessels, they are malnourished patient, and there is malignancy, and then we have to usually discontinue, or work should not be put at all. So these are the single-use portable negative wound therapy, or the PICU. Pico, and then it is battery powered, disposable, and does not require a canister, and delivers approximately. So these are the refined wax which are coming out depending on the need of the patient, and it has been smaller trials shown to be non-inferior as compared to the traditional NPWT system. Then we have another irrigation wax which also reduces the bioburden by dilution of the inflammation, and also enhances angiogenesis. Intermittent application may be good. The washing installation, saline installation is the best solution. Here also, saline is the recommended first line solution by the panel, and even PHMB is good tolerated, but it's a little bit carcinogenic effects have been suspected for it. And these are the combination therapies where we are in a relatively neuroischemic ulcer, we are doing the debridement, applying the VAC, and then followed by SSG. And then there may be even topical oxygen ozone may be given. The irrigation this thing, apart from installation irrigational VAC, apart from installation of the antiseptic solutions or saline, we are also using the oxygen supply in installation VAC. Similarly, topical oxygen ozone first to bring the granulations, and then followed by VAC therapy to increase the number of oozing points. So it may be gene expression through differential gene expression it may cause, and this improves the epithelialization and angiogenesis, and so its effect has been studied in animal models and preliminarily in humans in preliminary stages. Then again, wound margins, we will find that upregulation of the deoxyredoxin, and then it is premature. In the rat model, it has been studied, and it has promotes by reducing the oxidative stress and improving the proliferation and migration apoptosis this will promote the wound healing. So effect of negative wound pressure and wound therapy thermometry has been done, and they studied the various parameters related to wound size reduction and found the sufficient difference in the baseline and the day 21 values. And in this study, they also found that patients were highly satisfied with the NPWT compared to the conventional dressing, and the cost of treatment overall due to reduced hospital stay was much better. So concluding, I would say that NPWT has revolutionized the treatment of non-healing wounds, and it has a significant effect on the limb salvage. For better outcomes, we must do the guidelines and recommended. We must follow them, because the irregular application of VAC may lead to serious outcomes. So improved outcomes in infected wounds with installation nanocrystalline antimicrobials has been found. With change in pressure, mode, and duration setting, NPWT can treat most of the wounds, and it can enhance the healing and lead to wound closure. Portable devices and home care protocols are expanding usage outside the hospital settings, and it is an essential tool in overall multidisciplinary or cross-disciplinary management of the diabetic foot. Thank you, sir, for the patient hearing. Can't hear you, sir.
Thank you, Dr. Manisha, on such a detailed lecture on diabetic foot management by negative pressure wound therapy. Constraint of time, we'll take all the questions in the end. I think we'll move on, Dr. Jay, to the next.
Thank you so much, Dr. Manisha, ma'am. I think it was a very comprehensive talk on NPWT, and we request you to stay back so that we can have all the questions at the end. And we request all the viewers and all the postgraduate students who are watching us live from different part of the country, please post your questions so that we can have a fruitful panel discussion at the end. And with this, I request now our program director, Dr. Milind Ruke, sir, to take us through a very new and a very differential topic coming up next is on carexomar iodine, a new agent in a biofilm management. And now, without much wasting time, would like to now hand over this platform to Dr. Milind Ruke, sir. Over to you, sir. Thank you so much.
Okay. So at this point of time, I would like to welcome and appreciate Dr. Abhay Darvi, sir, who has joined, who is the MMC observer. Thank you, sir, for joining.
My pleasure.
Thank you, sir. Jay, I would like to start my last talk first, because one of my talk, which was now on biofilms, I will take last.
Sure, sir.
So I'm going to talk on the use of skin substitute in diabetic foot wound management. And so diabetic patients and wounds in diabetic patients are associated with neuropathy, peripheral vascular disease, and diabetic foot infections, as we all know. And what we have seen when treating these diabetic patients is a lot of impaired healing, prolonged inflammation, and reduced epithelialization kinetics. So the wound contraction and the wound healing is more suffered when you have a large area of skin which is lost with the loss of dermis. This is the emerging phase of diabetes longevity, and we see large wounds now, especially in government hospitals and late referral patients. And most of the time when we debride this wound, they exhibit a phenomena called as iceberg phenomena, where we find that the wound is small, but once we start debriding a large area of the foot, we have to debride, where mostly the epidermis, the dermis, and even the muscles are compromised. So does the dermis skin regenerate? After a deep skin injury in mammals, the wound heals, but the dermis cannot regenerate. Instead, collagenous scar tissue forms to fill the gap in the dermis, but the scar does not function like the dermis and often cause disfiguration. Now, we all know that the advanced glycation end products, they cause glycation of the tendons and the ligaments of the foot, and that causes altered biomechanics. So with the dermis gone, once you are trying to reform the foot or reconstruct the foot, it's very difficult only to put a skin graft or allow it to heal on its own. It will cause a lot of fibrosis. So closure of the wound and offloading is important in association with assessing the vascular condition, modifying glycemic control, debridement, applying different kind of moistures, bed, and time principle, which we are already doing. So we are going to now today discuss on this aspect of what happens when you have a large wound when the dermis is lost. So initially, we used to do local rotation flaps, pedicle muscle flaps, and free flaps. They require strict post-operative management and offloading to eliminate repetitive shear forces, pressure, and premature. Now, local flaps I do in my practice, where we replace the like tissue by rotating this flap in small, but we have also done in large wounds in a heel ulcer, where the entire ulcer is excised, and then we rotate the medial plantar flap, and we have good results. We have also done the sural artery flap, where non-dependent area muscle with the skin and subcutaneous tissue is transferred to the dependent area. But this requires a lot of expertise, and most of the places and with medical legal things, we require either a trained diabetic foot surgeon or plastic surgeons to be around to do these cases. And in secondary care hospitals, now we are expanding our medical education and medical teaching in different hospitals. So in secondary care hospitals, these facilities are at least this point of time not available. So we have seen now new evidence of bioengineered skin substitutes being used, like amniotic membrane, autologous stem cell therapy, fibroblast-derived dermis, and porcine small intestine submucosa, which has been used. And they play a significant role in the management of diabetic wounds by providing a scaffold for tissue growth and promoting the heal process instead of doing flaps. So we have graft jacket, Epicel, Appligraph. Now, Appligraph is not available. It's a bilayer thing. It's got epidermis as well as dermis, which can be put, but it is not available. So we have dermagraft, where human fibroblast and polygalactic scaffold, which is artificial, is used. Got integra, again a bilayered with a silicon layer, which is then removed later on after you graft it, and matriderm, which we are using now in collagen scaffold. The evidence shows that the treatment with dermagraft produced a significant greater proportion of healed ulcers compared with the control group, where we have done skin grafts or just allowed the WAC to heal the wound, or with only applications of growth factors. Now, these are some things that we used to do before using the dermal grafts. So no dermal substitute was used in this patient. Patient was not willing. So this was osteomyelitic. We had to remove the great toe. After removal, we had to do a graft from here. But because the dermis was not used, dermal graft was not used, this patient returned after about 6 months with a ulcer or a skin loss. The absence of the dermis leads to fragility, blistering, scarring, and poor osmosis. The dermis is vital for elasticity and mechanical strength, and hence a dermal graft would have helped this patient in wearing a offloading shoe and doing his routine work. This is another patient, a 56-year-old man, non-diabetic, a meat seller, very poor, comes referred by a general surgeon. Patient comes to our center with high pulse rate, frank gangrene with severe pain, ABI 1.2, luckily. So you have to have a good blood supply if you are putting a matriderm. So this patient, as an iceberg phenomena, you see this redness is spreading to the lower leg, and he was advised below knee amputation. We did an debridement. The patient was not willing for amputation. And slowly, after about 3 weeks, we had the wound this way. So we put an installation vac and we achieved a granulation tissue. We grafted him. He was very good during the COVID process. He did not walk much, but the moment he started walking with the offloading footwear, he was okay. But even after using a footwear, he developed this kind of ulcer in the 1.5 years. So if we had used a dermal, this is the retrospective thinking, it would have been helped. So we reviewed in the secondary care municipal hospital systematic meta-analysis things, and we found that compared with standard care, the acellular dermis matrix use was very beneficial for the patient, and it was also superior to appligraft. So we tried to do 24 cases in our setup. The initial thing was to do debridement. We used mechanical debridement, surgical debridement, and removed all the slough and necrotic area. This is a schematic representation. Then once the skin substitute was ready to be put, we also used in some cases negative pressure wound therapy. Then this substitute caused stimulation of cellular influx, extracellular matrix deposition, and reepithelialization. The graft slowly broke down and the remodeling occurred in patients. So this is one case, very bad osteomyelitis spreading across the midfoot up to the lower leg. We had debrided initially, and then we had to take the extend the incision up to the above the ankle, and then we put this is the dermal graft that we have put. This caused, and the second sitting we put a skin graft over it, and the patient 2 years free from any kind. This is a very interesting case. This is a typical iceberg phenomena. Patient comes referred by a physician, sugar very high, and he had a wound with communicating sinus to the lateral part of the foot. We found calcaneal osteomyelitis. We had to do the arterial Doppler. We found 1.2 as the ABI index 1.1. And then we did serial debridement. Every time we used to find pseudomonas. We used cadexomer for it. Sometimes we used WAC. We even drilled the calcaneal bore, did a partial calcanectomy, put cadexomer powder this time, and we found a good granulation tissue, which we again whacked. This is the dermal graft on the bone we have put. This is skin graft, and this is how the patient is after. So he has done very well. Last 3 years, he is not recurrent. This is a non-diabetic patient who was treated by a variety of hospitals with a large wound and a very ugly kind of thing, which is extending from the dorsal to the plantar area. And nobody had a clue. Last 32 years, he was suffering from this, not walking on this foot. We did an edge biopsy, 4 edge biopsies, and we thought it was malignant, but it was not. And we did a good debridement of this patient. And we found that the 5th and 4th metatarsal head had osteomyelitis all these years. I don't know why it had not spread up, but that is how it was. And on the bone, after debridement, the healthy bone, we put just a 3 millimeter Matridum patch. And in the second sitting, after 3 weeks, we put a skin graft, and we had no 1 year, and he's been working for the thing. So dermal substitutes in case with dermal damage, relying solely on the best epidermal substitute isn't sufficient for optimal wound healing. The absence of dermis leading to fragility, blistering, scarring, and poor cosmesis. Dermis is vital for elasticity and mechanical strength while walking. Dermal reconstruction becomes crucial when the original dermis is missing. Additionally, only 15% to skin grafts successfully integrate the wound and have total healing. And the fibrosis caused by it, especially in the plantar of the foot, is not will cause a problem or a recurrence of ulcer. So ideal properties of skin substitutes, whichever you want to use, should have improved host tissue regeneration, barriers protection and resistance to local infection, resistance to shear force when you're walking in a modified or customized shoes, improved cosmesis, easy handling and application, long shelf life, and cost effectiveness. So in summary, skin substitutes present a promising avenue for treating diabetic wounds. These substitutes offer advantages such as accelerated healing, reduced infection risk, and improved tissue regeneration. Cellular substitutes contain living cells like fibroblasts and keratinocytes, aiding in wound healing. So I think this is a good thing if you don't have a plastic surgeon around, especially in primary and secondary care center for general surgeons. Thank you. So I think we'll take questions after the next 2 lectures are by a very skillful surgeons, one from Coimbatore, Ganga Hospital, Dr. Madhu Perasamy. They are going to demonstrate surgeries which normal general surgeons do not venture into or do if they are not trained. And the first lecture is going to be by Dr. Madhu Perasamy. He is from Ganga Hospital, and he's a consultant plastic and wound reconstructive surgeon. And he has got a lot of publications under him. And he's going to talk on Keller's osteotomy for ulcer on the plantar aspect of the great toe. Over to you, Dr. Madhu.
Thank you, sir. So the topic for today is Keller's arthroplasty. So I'll start sharing my screen now. So the Keller's arthroplasty is it's a gap arthroplasty. I'm not sure if an arthroplasty for particularly for general surgeons means it is an operation by which we increase the function and mobility of a joint. So this operation is specifically for treatment of the great toe IP joint ulcer, particularly this ulcer. The other type of grade 2 ulcer is the tip or subungual ulcer, about which we are not going to talk today. Grade 2 ulcers by themselves constitute about 30% of all diabetic foot ulcers. And hence, treating the grade 2 ulcer alone has a potential to reduce the number of amputations by 1/3. So, to talk about this ulcer, we need to know about the pertinent anatomy of the grade 2. The grade 2 is the largest of the 5 digits. It consists of 2 phalanges, just like the thumb. It consists of the proximal phalanx and the distal phalanx, whereas the other toes consist of 3 phalanges. So it has only 1 interphalangeal joint. The other toes have 2 interphalangeal joints. So the outermost plantar layer of the grade 2 is the plantar skin and soft tissue, and particularly an abundant amount of plantar fat pad. And this fat pad, as you can see, is modeled in a 3-dimensional way so as to increase the contact area and reduce the pressure on the underlying plantar skin. So once we go through that, you can see that the next layer in the sole of the foot is the plantar fascia, which extends, there is a slip extending onto the grade 2. So this plantar fascia is like a continuation of the Achilles tendon with this, with the calcaneum acting like a sesamoid bone so as to turn the forces of the Achilles tendon in a plantar way to the forefoot. So it transmits the, it is a structure that helps to retain the arch, and second, to transmit the forces of the Achilles tendon to the forefoot. So once we go deeper to that, you have the first layer of the sole with the flexor digitorum brevis muscle in the center, the abductor hallucis on the medial side, and the abductor digiti minimi on the lateral side. These are all called intrinsic muscles. Intrinsic muscles meaning they arise in the foot and insert within the foot. The other type of muscles are that act on the foot are the extrinsic muscles, particularly the long extensors and long flexors, which come in the second layer of the sole. So these are muscles that originate outside the foot but insert into the foot. So these are called extrinsic muscles. So these are mainly the components of the second layer. As you can see here, the flexor hallucis longus, the flexor digitorum longus, and an important structure between them, which is the knot of Henry. So that is why it is very difficult for you to flex your grade 2 alone without flexing the other toes. So anytime, even as you are watching this program, you can try flexing your grade 2 alone. You will notice that all of your other toes also flex. It is difficult to, it is near impossible to flex your grade 2 as an isolated flexion. So the other components of the second layer include the lumbrical muscles, which arise from the long flexors and insert into the extensor expansion, and the quadratus plantae muscle, which serves to, just like the skin hook, it serves to turn the direction of the pull of the long flexors from the medial to a more central direction. So this is the quadratus plantae muscle here. So when we pass on to the third layer, you can see now that the muscles of the grade 2 take more prominence here. So the third layer, all of the muscles are to the grade 2. There are 2 heads of the flexor digitorum, flexor hallucis brevis, the tibial head and the fibular head, with the FHL passing in between them. The FHL is part of the second layer. So these muscles just lie underneath the FHL. The other muscle is the adductor hallucis, which again has 2 heads. It has a transverse head and has a oblique head. All of these muscles to the grade 2, they insert onto their respective sesamoids, and from there through common intrinsic tendons into the base of the proximal phalanx. The third muscle is the flexor digitorum minimi muscle, which inserts into the base of the little toe. And the fourth and the deepest layer, here the muscles of mostly do not go into the grade 2. They are the plantar interosseous muscles and the tendon of the peroneus longus, which inserts into the base of the first metatarsal. It is important in allowing the grade 2 to dorsiflex, because it causes a plantar flexion of the first metatarsal so that the grade 2 can easily be pushed up against the first MTP joint. So on the dorsal side, there are only two tendons that insert into the great toe. All of the extrinsic tendons will insert into the distal phalanx, whereas all of the intrinsic muscles, particularly on the dorsal side, the extensor hallucis brevis will insert into the base of the proximal phalanx. So on the plantar side also, it is the same. All of the intrinsic plantar, the flexors will insert into the base of the proximal phalanx, whereas the extrinsic muscles will insert into the distal phalanx. So once we go from there, now we need to know about how exactly the great toe helps in walking. So unless we know about that, we won't be able to understand why this operation is necessary in patients who have an ulcer. See, during walking, there are mainly two events that occur. These are called phases of gait. There is a stance phase during which the involved muscle, the leg, is on the ground, and a swing phase where the involved foot is off the ground and it is swinging forward in the air. So there is a difference between walking and running, and it's not very important to know that here. You just need to know that there are two phases of gait. One is the stance phase and swing phase, and all of the forces that cause ulcers act on the foot during the stance phase. That is when the foot is weight bearing. So for that, we also need to subdivide the stance phase into 3 periods, where the initial period is where the foot hits the ground as a dorsiflexed foot. A dorsiflexed foot which hits there is a heel strike, and which goes on to become a plantar flexed foot. So here it becomes from heel strike to foot flat. So here what happens is there is an eccentric contraction of the anterior groups of muscles. Eccentric contraction in the sense that there is an active lengthening of the muscle even while it is contracting. That is, there is a slow release of the length of the muscle. Otherwise, the foot will just drop onto the ground. So this is called an eccentric contraction, that when there is a lengthening of the muscle during an active contraction. So once the foot is flat and plantar flexed, the next event that takes place is the tibial rocker, where which the tibia moves forward on the fixed foot. Here you can see the plantar flexed foot again becomes a dorsiflexed foot. Mind you, these are all closed chain kinetics. Closed chain kinetics meaning that the distal part is fixed and the proximal part is mobile. So these are called closed chain kinetics. So when there is a plantar flexed foot, has now become a dorsiflexed foot. Here there is an eccentric contraction of the posterior group of muscles. But the great toe comes into play in the third rocker period, or the third period. Here, the great toe has to dorsiflex well to allow the foot to propel the body forward. This is called the metatarsophalangeal rocker. Here, the most important thing that has to occur is the dorsiflexion of the great toe. The dorsiflexion of the great toe here is not without reason. There is a particular reason why this has to take place, because a well dorsiflexed great toe causes a flexion of the first ray, preserving the arch of the foot. And this helps in weight bearing of the entire load on this small area or the head of the metatarsus. Otherwise, the whole foot will just collapse and fall down. So to preserve the arch, the dorsiflexion of the great toe is very important. And this occurs by a mechanism called the windlass mechanism. So here, as you see, the intrinsics of the foot are inserted in such a way, as I said, they insert into the sesamoids and then travel on to the base of the proximal phalanx. They are made in such a way that when you dorsiflex the great toe, the first ray will plantar flex. So this helps in the arch tightening and allowing the arch to bear weight, causing the foot coming into what is called a close pack position. So this helps in bearing of the weight during the terminal phase of gait, or the heel off phase. So how does stiffness of the first MTP joint cause problems? The stiffness can be divided into a passively rigid MTP joint, which is called hallux rigidus, or it can be a passive which becomes stiff on weight bearing. So this is called a functional hallux limitus, which occurs only when there is function going on. So as we said, this is the normal windlass mechanism. But if you see, the converse of the windlass mechanism is when you dorsiflex the first ray, the great toe will go into flexion. If you see the older picture, when we dorsiflex the great toe, the first ray will flex. On the converse, when you dorsiflex the first ray, the great toe will flex. So this, as just to recapitulate, this is because of the way the great toe muscles are inserted into the base of the proximal phalanx, the FHB, the adductor hallucis, and the abductor hallucis, and all of these muscles insert into the their respective sesamoids. And if you see, through a common intrinsic tendon, they will insert into the base of the proximal phalanx. So what happens when this great toe becomes stiff? So this is a normal great toe. So when there is a normal heel off, but when there is a stiff great toe, what happens is the patient cannot do a normal heel off. Instead, they will do a pronation of the foot, and they will do a rotation of the foot itself. And so they will walk with a high amount of shear in the proximal phalanx head. So that is exactly where the entire load is going to go, and that causes a plantar hallux IP joint ulcer over here. And the answer to which is to do a Keller arthroplasty. That is to disrupt the entire normal anatomy about which we were talking so long. So once we are able to disrupt this windlass mechanism, the toe will immediately increase in mobility. The mobility of the toe will immediately increase. So once it increases, this will lead to reduction on head of the proximal arthroplasty. So this is the normal joint. What we do is we excise the base of the proximal phalanx. You can see the excised base of the proximal phalanx here. And this is how it is exactly done. So we go through a dorsal incision. An incision is placed in a more staggered manner. The skin incision is placed more medially, and the tendon incision is placed more laterally. It is very important to achieve good hemostasis there. And then if you see, we don't go through the tendon, but we just cut adjacent to the extensor hallucis longus tendon and retract it aside, so that when you put staggered incisions, that is one incision on this side and one incision on this side, when you close it, they will again come together, and like a curtain, they will close in layers. So even if the skin incision goes off, there will not be exposure of the joint. So the next step is to take out all the soft tissues on the base of the proximal phalanx, particularly the EHB, and then using a sagittal saw, what we do here is we cut about 20 to 30% of the proximal base of the proximal phalanx. So once that is cut, we use a good Alice retractor and then slowly divide the plantar intrinsic ligaments. So as you see, a stretch is put onto the tendon, and the intrinsic ligament is cut, and the bone is delivered outside. And what is left is a good gap over there, and this causes the toe to become more floppy. You can see that these are the cut plantar intrinsic ligaments. And now with you can see that even when the great toe, the first ray is dorsiflexed and loaded, the toe can even still move. It can move very well. It doesn't become stiff as it would normally. So if we dorsiflex the first ray, the toe is still able to move, and this will immediately reduce the pressure on the PPX head and lead to a good stable healing of the ulcer. So, and then the wound is closed primarily, allowing the tendon to slide to cover the joint, and the patient is kept in a non-weight bearing position for about 7 to 10 days, and then slowly allowed to walk. Then once the wounds are healed, he is given a special footwear and allowed to go about. We have published a paper on this in the Foot and Ankle International, and in our series, we found that there was a 5% recurrence rate with an average of about 30 months. So this is the gold standard operation right now for a non-infected plantar hallux IP joint ulcer. So thank you for the presentation. Thank you for the time and the organizers. Thank you to Milendra sir for this opportunity. Thank you very much.
Dr. Madhu, an excellent presentation and video presentation, and this is what we require for the postgraduate students to know and to believe that this can be done, and surgical offloading can be done in patients, and they are very useful. So without wasting much time, the next speaker is going to be Dr. Amit Burande from Kolhapur. He is a MS orthopedic surgeon from Solapur, and now he's in DY Patil. He did his anatomy and as well as orthopedic surgery. Completed fellowship in diabetic foot surgery under Dr. David Armstrong. Completed ankle and foot fellowship under Dr. Rajiv Shah, and he is invited as speaker on state and national conferences. And he runs a hospital dedicated to diabetic foot in Kolhapur, Surya Limb Salvage Mission. Amit is going to talk on a very complicated diabetic foot entity called a Charcot foot, and I request him to be very specific about this surgery that he does and gives good result in skilled hands. Over to you, Amit.
Thank you, sir. Am I audible?
Yes, you are audible.
My screen is visible now.
Yes.
Directly, good evening, all in one. Thanks for the Defoot International officials and locator for the opportunity. I will directly start with the case capsule. 47-year-old man, type 2 DM on moderate control of HbA1c, neuropathic symptoms in 2 years, deformity in both fists in 1 year, no history of rememberable gross trauma, acute swollen hot foot in last 1 year, developed wound on medial side of the right foot, significant or intermittent serosanguinous discharge since 3 months back, and stroke to bone positive in this patient. So this is a clinical presentation, a swollen foot, medial deformity, perforation abduction. All lab is normal and HbA1c was 7.5. You can directly go to the X-rays, and what I want you to see in X-ray in the AP view is there is the collapse at the midfoot level and the deformity, so that the apex of deformity is on the medial side and the forefoot is laterally mobilized. You can focus here and you can see the osteolytic shadow in the bone, and as I already told, so bone to probe to bone is positive, and the osteolytic shadow, they are more in of the local infection of the myelitis, osteomyelitis. So what is the possible diagnosis in this patient? It's a Charcot foot deformity, osteomyelitis. It's osteomyelitis, is it acute, subacute, chronic, active, or a combination of both? So you don't need to tell what is osteomyelitis, so basically a bone infection. But what is the Charcot foot? Named after a French neurologist. Charcot caused by a progressive degeneration-induced degeneration of the foot and ankle joint, but not limited. I have seen patients having the knee Charcot as well. And the most important essential factor is the different kinds of the neuropathy. Metabolic and hormonal is the most common one right now. And leprosy was there just before this diabetic epidemic has begun. And it should be contributed by a trivial or non-trivial trauma. And what it causes is the autonomic dysfunction, the local hyperdynamic circulation, washout of the bone, and resulting into the fractures and deformities. It goes through the stages. I will not go into detail because I want to explain you the case capsules. You can go this in the next. And so in the stage 1, it is just a swollen foot without radiological signs. In stage 2, or actually stage 1, stage 1, there is a bony fractures will start, the limb is still swollen. In the stage 2, the debris will be removed, and the stage 3, the remodeling and the deformities will come. Most important factor here is knowing the area of the Charcot. So type 1 is in the midfoot, type 2 that is the hindfoot, and type 3A and type 3B are around the talus and the calcaneum. I'm fortunate as well as unfortunate enough to deal with all these locations of the Charcot and get opportunity to work on that. So let's come back to our case. This is the patient in the AP view. We are seeing the deformity. What we want to correct, to compare, I have taken a normal foot X-ray, talus to calcaneum and anterior column, and the tendo Achilles is acting. A is a normal. And what happens in Charcot is already it has gone from the ground that and foot has gone little bit in air, and actually when patient puts the pressure, it will go still upward, so the break will be in the midfoot somewhere, and it is because of the short endoachilles. So surgery has to begin, any Charcot surgery has to begin with. So point number one, take home message, every Charcot surgery will begin with the endoachilles lengthening or cutting if you are going the peritalar fusion. Now intraoperative planning again, that you cannot just do osteotomy on your own. I again confirmed with the 2K wires, confirmed that all essential bones are being cut, and I went ahead. After doing the osteotomy, what things I have done, this is the I mobilized, hold the foot on the medial side, fix it with the beam. This is the principle of beaming. I use the K wire. I will tell you why. Because that was an infected foot. What you can see on lateral side is again the bone graft. Why this graft is kept? Because if this fails, the foot will again go laterally, but this will act as a wedge, like the stopper in your door. If this fuses, this will not allow the foot to collapse again laterally. On medial side, you can see a lot of antibiotic coated bone cement, that is the stimulum. And this is an additional, I can say, the precautionary measure I took, that the distraction. So medial column is compressed and the lateral column is distracted in a simple way. This is how, and in the lateral also, I could achieve a significant restoration of the arch. So this was the maybe second or third post-operative day. Post-operative protocol is very important. When the bone is involved, infection is there, IV antibiotics 3 weeks, oral antibiotics minimum for 3 more weeks, even if there are no symptoms. Delayed stitch removal, strictly non-weight bearing 5 to 6 months. My protocol is minimum 6 months. Good metabolic control, BCS lab or cast for the 5-6 months. There was little discharge that remained for 3 to 4 weeks on the medial side, but that stopped and the slab was continued. At 12 weeks post-op, fixator is out, and I'm happy that the bone is looking uniting. Here is also uniting. You can see only 2 simple K-wires are holding all these structures. No need of very fancy implants. If your surgical principles are correct, no need of very fancy implants. I'm going to talk about it afterwards. So at the 19 weeks, all grafts are consolidated, united, fixed, foot is rock stable, but I'm worried that his opposite limb may require a surgery and need to augment this structure, because I cannot keep it in future. It should not break. So for the augment at the 19 weeks, this was the clinical picture. So I went for the consolidation, which is called as the beam screws. I did the fixation. This is the most important joint. Whenever you are dealing with the Charcot, especially midfoot and hindfoot, my philosophy is your patient's foot should look like a hanger, something coming from vertical, one anterior limb and one posterior limb. And you can achieve it by fixing calcaneum into the talus, talus into the midfoot, and midfoot into the calcaneum. So once you make this triangle, nothing can break unless and until he goes into the major accident. Okay, but again, I'm not satisfied in here. What is happening here is, after fixing all these things, there was a still little lateral instability. I cannot reconstruct. Ligament reconstruction is very difficult in this patient. So I've chosen a little safer option. Peroneus brevis, I shortened and I fixed, so I got the laterally stable foot. No peroneus longus, because if you shorten the peroneus longus, there is a possibility of having an ulcer below the head of the first metatarsal. Dr. Madhu is the expert in that area. So this was the picture, and this is opposite side. Now the decision whether to go ahead. I'm showing you this case very purposefully. It is very easy for me to convince this patient to fix the opposite side deformity, as I have done good on one limb. So this was the X-rays of the opposite limb. It is definitely deformed, but if you see, as the osteolysis was there in the first opposite side on the right side, you don't have the aggressive osteolysis. These are the serial X-rays. There is no much difference, and arch is well maintained. And comparative, I have put 3 months apart X-rays. I will prefer to observe this patient right now. Now we will, in short, discuss the principles and prerequisites of the Charcot reconstruction. So first is preoperative planning, the location of deformity. Depending on the location of the deformity, your osteotomies will be planned and your implants will be decided. So most commonly, you see the areas in the type 1 and the type 2. In type 1, you will get either a medially deformed foot or a laterally deformed foot. And type 2, you typically get the talus has started migrating from its position and coming down. We have the patients will go through. Second is proper clinical evaluation. A good vascular status, what is the stage of the forefoot, midfoot, hindfoot. That is the most important point for me is knowing the apex of deformity. If you know the apex of deformity, only then you can plan the osteotomies. And take my point, all osteotomies, they will be in a three-dimensional plane. There will be the rotational osteotomy. Then radiology is very important. I will tell you what X-rays are to be taken. These are the 6 X-rays. That is the foot AP, foot internal rotation, foot external rotation, ankle standing, the ankle AP, arc lateral, and calcaneum axial. In these 6 X-rays, you will have definitive plan of your surgery. MRI and CTs, they are just adding. Only if grossly infected limb is there, I need an MRI. Or if I am suspecting the talar avascular necrosis, whether to preserve the talus or not, then I will need it. Then IWGDF concern, especially I will just highlight this point, upfront cost of the implants and high postoperative medical complications. But from my experience, you will say that cost of the implants I have minimized. So you should know your implants. I will just go through the ring fixator, the plate, the K-wires, the screws. See, beam is a principle. Beam is not a screw. You can put a K-wire by beam principle. You can put a screw in a beam principle. So this is especially used for the hindfoot Charcot. That is why I called it the CPT nail. And these are the ring fixators. Bone graft, you must be ready to take huge chunk of the bone graft, especially when the talar loss is there. Iliac crest, proximal end of tibia from either side, 4 sides you can take. And there can be a cortical graft, or preferably you should go for the cancellous strut graft and cancellous graft, which are just compressed and mortarized. So this is how I would like. This is the chunk graft I will do for the major structural defect, and surrounding is the small graft, that is as well. So it is a osteoconductive and this is osteoinductive kind of the grafts. These are the bone graft substitutes. Still reasonably economic when very huge voids are there and very osteoporotic bones. I use these grafts. The only principle is they cannot be put just alone. Little bit of intrinsic bone has to be put. And the best thing is whatever the operative blood has come out, I will keep it soaked for a couple of times. So the general principles of surgery. So here I will go. There's a TA lengthening, osteotomies and bumpectomies, the bone grafting, stable fixation, implant of choice, post-operative protocol, and rehabilitation. So this is how I will just go through the slides as I have a very limited time. Talking on the Charcot in that time is not very easy. So this is the most favorite slide, or this is the most explanatory slide for you to understand the osteotomy planning. And this is very small video to see how actually the bone is osteotomized and debrided. Very important thing is most of the chronic Charcots at the stage at which we are operating, the synovitis has reasonably solved. But as compared to the normal joint, there is a still synovial bogginess. And what I am doing is removing exclusively all synovium. Whatever is the soft tissues remaining between the joints, we have to remove it.
That's a bit long.
Just let me know about the time. So this is about, this is how actually you debridement, the Siam fixtures. Then you should put the temporary fixation, what you want, how the foot you want. This is to be fixed temporarily, and then at this stage we'll put the grafts, and then we'll go for the definitive principle. So it's absolutely a circadian or the rhythm-based surgery. There is no shortcut. You cannot just say, and whenever you feel this is insufficient, you add something. In routine orthopedics, we say what we need is a stable fixation and reasonable alignment. For a Charcot foot, I want absolutely good alignment and a very rigid fixation, very rigid stability, and still I will protect it post-operatively with the absolute non-weight bearing. So there are some more cases. If time permits, I will just show you. Otherwise, we will go to the discussion component. Okay, sir? You are muted, sir. Okay, sir, you are muted.
I think our time is little less, so you can show one cases and then we can.
You want to see again this? I would like to tell about this patient. You can see on left side discharging wound 1.5 year. Foot is deformed, classical rocker bottom, but fortunately talus has not still started coming out. But you can exactly see where is the apex of the deformity. Wound is exactly there. It was a very long struggling case for me. I do the debridement, K-wires, Inzaro ring fixator because I was suspecting. When I suspect active infection, I will not put internal implants. I will just put minimum stabilizing internal K-wires and a ring fixator. At the end, 7 months, the wound has healed and a reasonable arch has been maintained. This is a forefoot was not a big problem in this patient. And this is the worst side, the same patient on the opposite side having a discharging, just a presentation of a discharging wound, but this is sarco with osteomyelitis at the hind foot at the calcaneum, what we are seeing. Here we went with aggressive just debridement because there was nothing to do. I didn't touch tender Achilles. I just do the all the infected bone excision. And at the end of 8 months, this lady was so happy to wear a normal shoes on bilateral side. Limited walk was allowed. She was encouraged to attend all the marriages and all family functions. So my aim of reconstruction of any sarco or any complicated diabetic foot patient should be back to normal with the normal shoes. At the most, I would like to give him some plantar insole modification. But though, if you want to give those bulky shoes and ankle foot orthosis, then we should not operate on this patient. Our aim is walk with Reebok. The happiness is immense when they enjoy the family function in these typical feminine team color shoes. You can see this is one more case. Talus is coming the ground and we have fused the same patient on the opposite side. A beautiful reconstruction of the arch. Should I stop here?
Okay. Yes, Amit, I think.
If there is any question, I will go ahead with the question.
Because we have got questions and I've got one more lecture to complete in 5 minutes. Okay, so I think we'll start the next lecture, Jay.
Definitely.
No, sir.
Yeah. Can I share?
In the stop sharing, yeah, I have done stop.
We are going to talk quickly before we start the discussion. Yeah. So there is a lot of talk about biofilm and the management. So to understand that, I'll quickly go through this small lecture of factors inhibiting wound repair. The most important factors that we see is the increased bioburden. And what we fail to detect is out of 4 in 5 chronic wounds, if you see the published data, have biofilms. Now, what are biofilms? Biofilms are polymicrobial infections where there's a core group of bacteria surrounded by planktonic bacteria, and they are covered by something called as a slimy barrier of sugars and glycocalyx. It's called as extracellular polymerase cover and water produced by themselves. And this barrier protects the microorganism from external threats like host defenses and antimicrobial therapy or local applications and even antibiotics. Now, why are they able to do? Because they live in colonies, they communicate through each other through water channels. They distribute water nutrients inside the colony in such a way that they live very securely. They pass the genetic information in such a way that they develop resistance to antibiotics and local preparations. If you do debridement of these patients, you will see that there is an immediate recurrence of the biofilm. When you see the microbiology picture, there will be mixed organisms, about 2 or 3 in, or sometimes 4 microorganisms in one tissue culture. So you have negative bacteria more common in this, like Escherichia coli, Pseudomonas, Klebsiella, Proteus, and less gram-positive bacteria in biofilm. So there are stages where within immediately after minutes of attachment of this kind of bacteria, they start forming biofilms and they mature in hours. And once these are released in the general circulation, you get a phenomena called SIRS. So when you debride this wound, they regenerate fast, and there has to be, and why this happens is because there is a prolonged period of inflammation. There is a upregulated immune mechanism getting operated where influx of neutrophils happens because of local level immune disorder. A prolonged inflammation occurs and increased levels of matrix metalloproteins 9 and 16, which accumulates and cause chronicity of the wound. Now, the diagnostic guideline to recognize biofilm presence is in the wound getting stalled. It is not healing well. So, heavily exudating wound covered with fibrinous necrotic tissue requiring repeated debridement but recurs in 24 hours. Persistent wound infection despite the correct dose and duration of appropriate antimicrobial therapy. Microbiological evidence of localized infection with polymicrobial infection. So why are biofilms so difficult to manage? Chronic long-term infection resistant to host defenses, difficult to diagnose, frequently resistant to antibiotic therapy, and difficult to treat. Only cure may be removal and avoiding reformation. The principles of wound biofilm management is the gold standard of debridement, followed by an anti-biofilm strategy where you give dressings in such a way that they don't recur, and then you put something like a negative pressure wound therapy, reassess the healing. If it is recurring, you go back to your debridement and putting the anti-biofilm strategy. So this is what we have seen published data that only debridement is not going to work in biofilm. You have to have an anti-biofilm strategy. Now, what should you do after debridement? Whether it is scalpel debridement, ultrasonic debridement, or enzymatic debridement, is to put selective biocides. So there are certain things which have been used now: cadaxomer iodine, PHMB, silver, hydrophera blue, glutamate sorbact. There are certain things in pipeline like lactoferrin, xylitol, farnesol, surfactants, polexamer, which are anionic surfactants and fatty acid gels. In India, the very cost-effective thing that I've been using is cadaxomer iodine, which is a time-tested iodine, but this is released not like povidone iodine, but in a sustained manner. Some cases where this is the patient with a large abscess in the toe with loss of soft tissue, we did an amputation, and this is how the application of cadaxomer iodine is done. But it is very tedious. It was very tedious. There were small beads, and you have to be very, very careful while applying. You cannot press, or the beads would break. Now they have come up with cadaxomer powder, and this has got 3 components in this. These are some of these. So this is how you got the red granulation tissue after applying the cadaxomer iodine. These are some more cases with topical things and the wound turning red. Some patients, we have to combine it with negative pressure wound therapy. One more case where a classical biofilm, which was debrided, then cadaxomer iodine was used, improved granulation tissue in 21 days. So the 3 components of this is polexamer, which cleans and breaks biofilm. This is an anionic surfactant, so it is less toxic on the patient. Cadaxomer is a catalyst which has got a hygroscopic property which dehydrates the extracellular membrane and causes breakdown of the extracellular membrane of the biofilm, absorbs exudate and prevents biofilm reformation. Iodine is time tested. It is in the bead form, which is secreted for 72 hours, and that is how it becomes a broad spectrum antibacterial. It is found to decrease the Pseudomonas and even the Staphylococcus and MRSA organisms. In short, it is a desloughing, exudated, decreases exudate control, antimicrobial action, and provides a moist environment also for the wound to heal. Some studies, so these are the studies which were done in about 18 patients, small studies. We also have published that data from Kurababa Hospital. where we found that cadexomer iodine resulted in microbial load reduction in 78% in one study. In the second study, about 64.7% patients showed significant reduction in mean microbial load post-treatment with cadexomer iodine. When this cadexomer was studied with different other ointments, they found superior action as compared to PHMB, which also has a good action, and hydrophora blue and other octinide. In summary, biofilm is a major concern for healing wounds, and in wounds are difficult to diagnose, treat, and frequently resistant to antibiotic treatment. Debridement alone would be insufficient to manage biofilms in wounds. Use of antibiofilm agents and selective biocides like cadexomer iodine and other agents that I mentioned showed promising results. Literature supports cadexomer iodine as most cost-effective in wounds complicated in biofilm in government hospitals and other hospitals where it would be a cost-effective management strategy. Thank you. And I think we'll go now to the question answers. For that, I would like Dr. Amit Nagate to join as a moderator and help me in asking questions. He's a consultant diabetic foot surgeon from Aurangabad, organizing secretary of DEFCON 2016 and organizing secretary of DFSI Midcom Pune. He's also a member of DFoot International. So I think, Amit, you can start asking questions to the panelists.
Thank you, sir. Thank you for your kind introduction. The first question goes to Regi, sir. What kind of post-operative antibiotic care or profile of antibiotic which you will use in DF?
Sorry, can you repeat the question? What antibiotic? Sorry.
Yeah, what antibiotic protocol are you going to use, or the choice of antibiotics for DF specifically, pre-operative and post-operative?
As we said at the routine, first of all, hi Amit, nice
Hello, sir.
seeing you after a long time. Yeah.
Yes.
Yeah, for skin and soft tissue where gram-positive coverage is in fact is important, I would prefer a combination of amoxicillin with clavulanic acid. Classically, that suffices for those. And as we said, in severe infection or in necrosis, where gram-negative infections are predominant, then a combination of clindamycin and piperacillin tazobactam is something which we are using as a protocol. In still severe infections and septicemia, then meropenem can be added. This is what we follow in our routine surgical practice over here.
Okay. So just like to extend the question, there is always a doubt that we need to take a deep tissue, we need to take a culture report. But what kind of culture sample are we specifically looking for, and we should send it across? This is what the general mistake done by most of the surgeons which are operating, or physicians which you were taking care of. So what kind of specimen would you like to suggest, and what is the need of it? Why is the need of that specific specimen?
It has been in the past that we were always sending pus for culture and sensitivity, but now the standard protocol is that one has to send tissue, especially infected tissue or slough, and it is best to send tissue from deeper structures. One, because on the surface there may be more of contaminants which are actually there but not actually causing infection or tissue destruction. It is only in the destroyed tissues that you can get some tissue which is slough, dead tissue, which you should send for examination.
Sure.
But
Thanks.
the standard protocol is to start broad spectrum antibiotics which are covering gram-positive as well as gram-negative, so that by the time you get your culture and sensitivity reports, the patient is not further landing in septicemia. But as we have been saying time and again, the most important thing here is that time is extremely important and source control is extremely important. So a good debridement, which I also said in my talk, is one of the most important takeaway message.
Very true, sir. Very true. My next question goes to Manisha ma'am. what are the contraindications of NPWT?
Hello, Dr. Amit. Thanks for the question. Thanks for the question.
Put on
And
video. Yeah.
yeah, thanks for the question. And I have already mentioned that presence of in the one of the slides that the main contraindication is the presence of infection, ischemia, and the if there is lot of infection ischemia, if there is lot of infection ischemia, these are the main this thing. And we have also decided that it should be AB index should be between 0.9 and 1.3, TCPO2 more than 40. So these are the things, and any coagulation defect or any bleeding disorder which are pre-existing, and PTINR is more than 2, then we should again think of not applying VAC. Any hidden pockets of infection which are present, then we avoid it, better avoid it. As for vascular or the ulcer, I've already told we should first go back and revascularize and then restart it, or or topical oxygen therapies may be tried to increase the oozing points, and then after that VAC may be applied. So these things we have to consider. Apart from that, if there is maceration or leakage, and or leakage induced maceration, then also, or there is sometimes blister formation on the skin, then or the patient is not tolerating the pain during dressing removal, then it may be unacceptable to the patient. It may not be tolerated by the patient, then it may not be allowed. Then certain patients may prefer it from the ambulatory or home things. Then that may also be factor. So these things have to be. If there is any skin disorders or skin problems also, then also we cannot apply. Although protective skin films are available if there is something minor in the skin, but otherwise we mostly avoid in these patients where there is a lot of fungal infection, etc. We cannot apply it. Anything I missed?
That's only the vascular. If the vascularity is low, you should not use negative pressure wound therapy. We'll talk again after some time. I think Dr. Abhay Dalvi sir has put up his hand, and sir,
No, I'll come in last as a summary, please.
Okay. So I think the next question is to Madhu. What is a modified Keller's osteotomy? And is Keller's osteotomy the best procedure for plantar ulcer? You do it in the first go, or you wait for some other procedures before you advise Keller's osteotomy, because patients would not accept immediately. In our practice, we have noticed.
Sir, what from our experience, the primary operation that is offered is Keller arthroplasty, because mostly the patients who come to us as a tertiary center, they've been through multiple options. They've already worn so much of footwear. They've tried everything they can. And then since we are, there is a bias in that. There is a bias in that. But if you see, as of today, the government of Tamil Nadu has taken up surgical offloading very seriously. And all government hospitals are the general surgeons from government hospitals are being deputed to the nodal center, which is Tanjavur Medical College, and surgical offloading is being taught to them, and it is being taken up in the government hospitals itself. So there is a lot of awareness that is being created, at least in Tamil Nadu, and people even in the villages through the public health system. So when the public health system is involved in that, the people are really convinced and they are ready for the operation. So as a protocol, we offer the procedure that has the best cure rates with the least recurrence rates, which is the Keller gap arthroplasty for plantar hallux IP joint ulcer. And we would recommend it as the primary procedure to be offered to the rural patient who particularly are not very good at sticking to wearing the footwear regularly and following strict instructions regarding other conservative offloading methods. And if you see the IWGDF guidelines also, right now the gold standard that is being advised for any plantar non-infected wound is a total contact cast. In fact, the guidelines advise that we should not prescribe footwear for active plantar ulcerations, particularly those of the forefoot, midfoot, and hindfoot. So when all of these, and when the total contact cast fails and other conservative methods fail, the final option that the guidelines submits to is surgery. So at least we think that primary surgery is good for our patients. And coming to the second part of your question, which is what is modified Keller's arthroplasty? Modified Keller's arthroplasty is nothing but it is an interposition gap arthroplasty. That is when a gap arthroplasty is where you create an artificial gap between the bones, but there is a chance that this can reunite, particularly since one of the raw areas of the bone is present, and there can be an amount of fibrosis over there. So to reduce the amount of recurrence, it can be either a natural inert material like a tendon or capsule of the joint or whatever. You can put it in between the raw bone surfaces, but usually in Keller gap arthroplasty, because one surface of the metatarsal head has the cartilage intact, bony union is very, very rare. So that is why I said there is only a 5% recurrence rate. So, and studies have been there which have compared simple gap arthroplasty and interposition arthroplasty. It has been found that there is no advantage in doing an interposition gap arthroplasty.
Do you
So
offload?
modified Keller does not offer any advantage over the original Keller.
Do you offload your patients after Keller's osteotomy?
Yes, sir. All patients are offloaded because when you do a Keller, you disrupt the windlass mechanism that will increase the load on the remnant metatarsals, particularly the second metatarsal head. So there is an increased chance of a transfer ulcer in the other metatarsal heads. So we would advise everybody, once the foot is in remission, we do advise everybody to wear
know them, it's our duty to make them aware that all these surgeries are not like just a simple go surgery. But my experience is sarco patients are ready to write whatever you want them to write, whatever you inform them, because most of them, they come to me like, everybody has suggested amputation, can you save it? But failure, fortunately, I haven't still faced failure only because I do a good, absolutely non-weight-bearing offloading minimum for 5 to 6 months. And I choose the time of surgery very carefully. The recent guidelines of hot process, especially in Europe, are going whether you should start operating on the stage 0 or stage 1. And the papers are published, but is on the discussion mode. I operate only on late stage 2 and early stage 3 patients. Grossly infected foot, I phase out the surgery. In phase 1, I do only infection control. And phase 2, I try to use the both.
Thank you. Amit Nagade, any more 2-3 more questions before we close?
Yeah, there is one question, Burande. How do you differentiate between an infected foot and a charcot foot? Usually happens because the charcot presents with a red hot foot and it is infected, not infected. The bones are distorted. If it is osteomyelitic, non-osteomyelitic, so how you plan to differentiate between those?
The history is very important. That how all it started. Like tomorrow, I will be operating on one patient. Patient was presented to me as a sarco foot. But when I took a very deep history, something like patient had 2.5 years old trauma, significant trauma, not the trivial trauma. Patient is a diabetic patient. Patient was offered a surgery, refused surgery, that went into some deformity. He walked on the deformity. And now when I see the X-ray, there is all the talotibial distortion is there. But foot is absolutely normal. Everything below the talus, everything is normal. So that is just a neglected non-union of ankle fracture. In a similar way, a typical midfoot deformity or a typical plantar ulcer, the talus is coming down or the midfoot is broken, that is 99% Charcot unless shown otherwise. But as you are rightly said, there is always a possibility that if you give me a permission, I have kept that slide reserved. If you give me permission, 1 minute, I will show you. It will clear all the doubts and all the things. Just let me have this slide. Can Can you see the slides?
Yeah.
Yeah, this was the
Yeah.
patient. The patient was, I was involved in this surgery. I was called to operate outside Kolhapur, typical swelling, diabetic patient, significant neuropathy. This is the X-ray picture. And in this kind of picture, I have operated 3 this kind of patients, and this can be a subtalar Charcot or this can be a pure infection, but I would not take risk. So just see what happens when I approach this patient. Yes. The pus, it's a frank pus which is just pouring out. So there is no question of doing any definitive procedure. We just went inside, very good debridement, and debridement. No bone graft in such a badly debriding wound. You can appreciate the stimulant with antibiotics and just a fixator. And this is the result at the end of 5 months. I was very patient in this patient. What has happened is now, because of infective arthritis, talus and calcaneum has fused, but the tallow tibial joint is reasonably preserved and the foot architecture is reasonably preserved. I would not like to hurry and operate in this patient. So as I have initially only told that infection and Charcot infection, because osteomyelitis can cause a broken limb mimicking a Charcot, and Charcot can got secondary infected and mimic osteomyelitis. So these are absolutely borderline patients, and Eisenhower's classification doesn't include this. I am trying to compile the data and I will get significant number of patients. With evidence, I would like to show this data.
Thank you. Amit, any more questions, or we can ask Dr. Abhay?
There are a couple of questions actually. One is, what is the prospect of Versajet for debridement? Interesting question. Anybody can take over it.
I think Tushar, you can answer if you're using Versajet.
No, I have not used Versajet. I have not used Versajet.
So Versajet is a debriding modality where you try to do a safe debridement without harming the tissue. So it is just, if you have a good commercial, want to have a good commercial impact on the patient, because you can as well do a good surgical debridement. I have never wanted Versajet, but it is as you know, the wound market is commercially driven and pharma driven. So if you are working in a plus hospital and you want to impress the patient, very rarely Versajet would be required to the patient.
Okay.
But it's a good modality. If you
it's a good modality actually.
high, very costly.
Yes. There is one question, interesting one. Where do you put ortholytic debridement on a scale of 1 to 10? Tushar sir, can you take it?
Can
you repeat again? On a group of on a scale of 1 to 10, where would you put?
Scale of 1, where you put an ortholytic debridement agent on scale of 1 to 10. The person has not mentioned ortholytic debridement agent. Could you guide on the ortholytic debridement agent and where you can put it from 1 to 10 scale?
In a small wound.
Can I answer that?
Yeah. Okay.
Yeah. If there are grossly intact anatomical structures that are sloughed out, that is, if there are dead, grossly intact anatomical structures such as a large tibialis anterior tendon, the extensor tendons, or a large eschar of skin and soft tissue, then autolytic debridement has no. There, sharp mechanical debridement is better. It is cheaper, it is faster, and it gives better results. But in areas where you're not able to, like a biofilm or something is there, and there is superficial surface slough is there, a large area of where it is, you cannot delineate the anatomical structure and have a clear, you cannot give a good clearance. There is a surface slough. For example, a below-knee amputation is done and the surface of the muscle and the fat is still a bit ischemic and sloughed out. In such areas, autolytic debridement is better. So where you can't do mechanical debridement, an autolytic debridement is better.
May I add something?
But in yeah.
Okay, sorry, you continue. I will talk.
No, it's done, please.
Okay, and I have found it working very well, especially in the connective tissue disorder, the vasculitis wounds. Because you might be remembering we had discussed that abdominal patient post-cesarean, a very big necrotic scar was there, and every time the surgeon would do a mechanical debridement, the area will increase, the vasculitis will take more rampant, and it will become more flat. And so we just started autolytic debridement. Within 4 to 5 days, we got reasonably good slough out. And that patient was turned out to be the antiphospholipid positive syndrome. Similarly, I have got 2 patients with the ANA. You debride, you cut it, and ulcer depth will increase, ulcer appearance will increase. It will start getting more fluffy and pouring pus. But you be gentle with it. Just keep on gentle dressing with other immunocare modalities and the basic care modalities. They will be there. This is one more area.
Amit,
But
last question.
please, I think as the audience in general should remember that these are exceptions. These shouldn't become the norm.
No,
Because there is nothing like a surgeon's knife that can clean a wound.
I specifically tell you,
Sure.
because in vascular,
No. Just to get the message.
Right.
I perfectly,
Yes.
I agree with Amit. Yeah.
Yeah, I think there is one just last question. Just sum up. There is one question named as protocol for local management. It's a vague term, but could anybody take it and just sum up in short? What would be a protocol for local management? It could be a wound management, I think so.
Yeah. Okay. But
It's just a vague
if
question.
there is,
Just sum up.
yeah, wound management. Okay. For example, let's take it as wound dressings, as I always say.
Yeah,
that. Wound dressings. Yeah, wound management, local wound management, or wound dressings. See, wound dressings you can just divide into 3 separate procedures: cleaning of the wound, topical application, and cover. If you break it down, it's very simple. So, cleaning of the wound is usually best done by a detergent and mechanical cleaning with water. That is what we think. So some people may prefer to use any. There are multiple other agents for cleaning of the wound, PHMB and things like that. But we prefer soap and water, just plain soap and water. If the patient is very afraid, you can use normal saline. So cleaning of the wound, mechanical cleaning of the wound is best. So that will dilute the biofilm. It will disrupt the biofilm. It will take off the slough. What loose slough is there, it will take it off. Then topical application. Topical application depends on the requirement of the wound. If it is an ischemic dry wound, you need a hydrating agent like an hydrogel. If it is an infected wound, you would require an antiseptic like silver and copper and whatever agent you want to apply on it, particular to the, if it is Pseudomonas, you can put acetic acid or whatever you want to put. If it is a clean wound and with a granulating bed, you want it to epithelialize, you can apply platelet-derived growth factors. So it all depends on the need of the wound. And cover depends on the discharge of the wound. If it is a low exudating wound, you need to apply some cover which has a low absorptive capacity, which are cheaper. If it is a moderately exudating wound, an appropriate cover. And if it is a high exudating wound, you need to apply either a alginate or a foam. Very simple. So if you just take it as cleaning, topical application, and cover, you break it down like that, then it becomes very easy as to what to apply in which situation. That's it, sir. So that is how we take our protocol of local management of the wound.
Very nicely put, Madhu. I think we have overshot our time, 15 minutes, and I'm very thankful to the observer, our Dr. Abhay Dalvi, sir, who is still there with us. And sir, any comments from you, sir?
Yeah, I don't know most of you all, but I can only say that since I passed my MS and continued on the staff of St. J.S. Medical College and KEM Hospital for 40 years, 36 as a staff member, I've treated a lot of diabetic foot patients and I was always frustrated in treating them. I'm so happy that there are dedicated people who are looking at diabetic foot as a specialty, and I congratulate them because it's an extremely complex problem. To me, diabetic foot has multiple problems which involves a surgeon, maybe a vascular surgeon, in the sense the entire diabetic foot is surrounded by surgeon, peripheral vascular disease, neuropathy, osteopathy, etc., etc., and is an extremely evolving system. And each one of you all are doing an excellent job in your own field. I think all of you all should come together. I know the associations have come together, but some sort of a algorithm has to come into system where everybody follows a particular path and involves a particular specialist as and when time comes. Now, just a general question, anybody can take it, that patient comes to you with diabetic foot. How do you know the role of vascular disease, neurological disease, and osteal disease? Osteal disease I can understand, for me, X-ray and osteomyelitis will be told. But I have learnt of so many things like osteotomy, etc., role of an orthopedic surgeon in treating diabetic foot. Ruke, I will request the pharmaceutical company to let the PGs who are attending know how does whose role and when it comes in, and how do you identify a person and how do you change a treatment when you know vascular component is important and neurogenic is important.
So to answer your question, sir, as a default, all diabetic patients, whether type 1 or type 2, has some element of neuropathy. So detection of neuropathy is very simple. There are things like, measuring the hot and cold perception, which is the first sign of losing.
No, that all PGs have already seen the person talking about it.
Yeah, once we do that, once we know that there is neuropathy, we feel the pulses of the dorsalis pedis and posterior tibial. We see for capillary refilling. We do an ABI index. If the ABI index is between 0.9 or 1.2, or if the TBI is toe brachial index is low, that means the patient has a vascular issue. Before that, the history taking, if the patient gives you history of intermittent claudication.
No, that is all done, Milind. My question was, in the study that was done both by the international speakers as well as the national experience, in their experience, how do they change the treatment basis of vascular disease is more, neurological is more, and how does the treatment change? That's what I was, because otherwise everything has been good. One more question I want to ask you is, as a person who has taught for a long time, there is a concept of angiosomes as far as peripheral vascular disease are concerned. And as I have understood what are angiosomes, grade 2 has the best of the blood supply. So does your diabetic treatment change because most of the images that I saw where grade 2 was gangrenous, and grade 2 is the last one to go in isolated peripheral vascular disease. So what is different here in diabetic foot?
May I talk, sir?
Yeah, please.
Yeah, Amit, please. Yeah, Amit, after you. Yeah.
I would like to always tell all PG students, focus on history and the way it all has started. History, and history. Whether there is a history of extrinsic trauma, intrinsic trauma, significant trauma, de novo, and duration. And when patient comes in your OPD, the location of the wound is going to tell what is happening there. Like tip of the great toe or any toe, there's a clawing, so neuropathy. That Madhu has shown that area, typical neuropathy. Coming little back, the head of the first metatarsal ulcer, that is again a neuropathic. Anything on the plantar side happening slowly, happening de novo, is a significant neuropathy. Anything happening at the tip of the toes and little bit of infective or very small trauma history, they are more or less a neuroischemic. The patients who are having all of a sudden a dry kind of a gangrene or development of the huge abscesses, they are more likely to be vascular deformities and instabilities. They are more in favor of the Charcot. The long-standing, any wound that is not healing and you are having a deformity, it has to have osteomyelitis component below that. And when this all diagnosis is when just the patient has walked in your OPD and he's sit and you are talking with him. Once actually you touch with him, whatever the classical investigations are to be done, like doing a monofilament test or the vibratiometer or doing a plantar fascia studies, this all has to happen in the OPD of a diabetologist. When patient has come to a diabetic foot surgeon's OPD with the wound, he has already missed that birth, and we don't need a monofilament to document there is a neuropathy. Ulcer itself is documenting there is a neuropathy. And when you are actually touching the patient, it is a strong recommendation that for every patient you do minimum arterial Doppler. It will be a very objective. It will be medico-legally very important. Then you take your patient for surgery. When in surgery and after surgery you find gross ischemia. I am not talking about only 1% of those patients who have come as a black toe or a black foot, which are classical vascular cases. Most of the patients, you will see that Doppler report is showing the tandem areas of the fast calcification, and few vessels are showing monophasic, who are showing the resistance kind of the flow. You start operating on that patient. If your post-operative view shows the wound is not doing well, then again involve the vascular person, but 90% of the times you don't need to do any vascular intervention. Because a vascular intervention in non-required situation, it will aggravate the vascular occlusion. This is how take my patients. Very practical approach. You don't need to have any classical guidelines, classification or something like that. The wound is telling that what is the problem.
Good, Amit. The basic thing I just wanted to come to for the benefit of the PGs is that as far as my knowledge of vascular anatomy is concerned, grade 2 should go last. So if grade 2 is the first presentation, one should consider not only vascular disease, but also neurogenic disease, which are combined together to give this type of presentation. That's what I wanted the PGs to know.
90%
It can also be because of infective embolus.
Yes.
Okay, you are the best people. I always, if a diabetic foot comes to me, Tushar will smile. I just send it to him.
No,
and he saved a lot of my patients. So
what I am trying to say here is 90% of the grade toes which I have amputated, they are a classical neuroischemic. Because of the neuropathy, there is a subtle trauma. Because of the ischemia, wound is not healing. Infection is taking place, that is causing local embolus and vasculitis, and you lose the grade. Very rarely you see the grade toe being loose for the pure vascular reason.
I think Dr. Manisha wants to say something.
Yeah, yes, sir. Good evening, sir. Sir, I just wanted to say, even if you feel that you have good bleeding at the debridement site, and its palpable pulses are there, still it does not rule out a ischemic component or a proximal block because of the segmental pattern of blockage in the diabetic. So you have to do a color Doppler assessment if the AB index is deranged. And so hence, even though they say that ABI is less commonly performed now, I am doing it as a routine. And if the ABI is showing it is less than 0.7, I definitely go for a Doppler. And it is even segmental measurement of blood pressures are done in the focused vascular clinics, which I am not doing. But a good assessment with a Doppler is essential if the ABI is deranged, and hence the patient must follow a particular protocol of assessment of neuropathy with the biodosimeter and with the vascular assessment, and then go for surgeries. So neural and vascular assessment is an essential part, along with the pressure studies, which are essential.
Madam, how good is Doppler to know what is the flow through the medial plantar artery, lateral plantar artery, peroneal artery?
Sir, even
if I can,
yeah, Madhu, please.
If I can answer these questions, yes, sir. Yes, sir.
Sir,
to answer your, madam, just can I answer that?
Fine. Go ahead. Go ahead.
Yeah, no problem. To answer your question first, which Amit had answered, because I told that I would also take my turn on that. The protocol, with all due respect, all of the protocols that we are currently following as surgeons have been narrated by the physicians. Yeah, what we are following is a physician narrative right now, and they are starting to see the surgeon side of it. Because we think that all of the feet are ischemic feet. No, it is 85% of, as Amit said, 85% of our diabetic foot problems don't need any vascular intervention. To decide whether it is a vascular problem or not, we use a clinical examination. If there are no pulses, we would do a Doppler. But and if the Doppler shows ischemia, we would do an MR angio and then call the vascular surgeon in for an intervention. Otherwise, if we feel that there are palpable pulses, then we usually go ahead directly. As plastic surgeons, we go ahead directly and start treating the patient. If required for medico-legal purposes, you could take a Doppler to document that the vascularity was good, so that if there is a problem later, you always have a defense on your side.
Sir, the
So
most important thing that I want to come in, Madhu, sorry to interrupt you.
Yes,
is
no problem.
Your pulses are normal, your Doppler anterior ABI index is normal. There are very rare cases, which sir was saying about the gangrene of the toe, where you find the capillary. It's a very simple test. Capillary refilling is not happening. So there is a distal obstruction of the dorsalis pedis or the arch, which can occur in some patients. And even if your proximal pulses are okay, distally you may get a block and you may get a gangrene. So that you have to be very careful by doing something like toe brachial index or capillary refilling test, which is 3 to 5 seconds it should refill. That's a very good test for government hospital PGs to know the terminal pulse circulation, how it is, a clinical test.
And,
so don't you think, Milind,
Yes.
I'm wise enough to refer patients of diabetic foot now that I'm in private practice to diabetic specialist?
Yes, sir. You have not referred me, sir.
Yes.
Now you and Tushar should not fight. I am observer for medical council. Anyway, congratulations to each and every, not only international, but I think the national speakers were very